o'clock. Oh, sit in the big chair. All right. We're starting off this morning by playing a game of musical chairs. I don't hear any music, but anyway, my name is Wayne McDonald. I am the chairman of the Health and Human Services Committee and Elderly Affairs Committee in the House. And I've been appointed, as all of us have, to this committee. And I would like to welcome you all here. And I believe it would be okay. And at this point, I guess we do the roll call for attendance. Who would? We have no clerk yet, right? Okay. So I see that on the agenda. So I would certainly welcome any advice as to how we proceed on that. Attorney Williams, do you have any advice?
You can just write down who's here, sitting at the table and vote for the best.
Okay.
I don't see anybody who
Would a sign-up sheet be appropriate to pass around? Okay. Representative King, could you pass one around? Could you, I just want to pass around a sign-up sheet for everyone so that we can record who's here. Representative Weber has one. So we'll pass that around. I am advised that we do have a quorum this morning. So with that, as that's going around, let us proceed to the choice of our officers. And I'll open the floor for nominations for chairman of the committee, of the Oversight Committee.
Mr. Chairman,
Yes.
this is Representative Merchant. Thank you for convening us today. I would like to place into nomination as the chair, Representative Pearson.
Thank you. Is there a second to that nomination? Nomination's been made by Representative Merchant, seconded by Representative Weber. Are there any other nominations? If not, I will close nominations, and I guess it would be appropriate. Well, all those in favor of Representative Mark Pearson, please signify by saying aye.
Aye.
Opposed, nay. Motion carries. Congratulations, Mr. Chairman.
Yeah. The chair wishes to nominate Wayne McDonald as vice chair. Is that agreeable
Second.
to everyone? Thank you. Representative McDonald is chairman of the BEST Committee in the House, Health and Human Services, and spent many years working at the department.
23.
Chair wishes to appoint Representative King as clerk, and Representative King, at some point, would you find an assistant clerk of your choosing? I like to do that. I do that in my children and family law. I did that last time in Health and Human Services. Not only does it give a backstop in case somebody's absent, a backstop who is trained, who knows the job, it also means if we go at a terribly fast pace and we're outspeaking someone's ability to write, there is somebody right there in place. Senator Gray, to your knowledge, who are the other senators?
According to the list online, it's myself, Cindy Rosenwald, and Senator Kevin Avard.
Thank you.
And Attorney Williams, you said that Senator Avard was not aware of his appointment until just recently? And Senator Rosenwald had I forget what you said about her. Oh, okay.
She let me know that she would not be able to be here today, so it's an excused absence.
Thank you very much.
So we have. Thank you, Senator. I think we can pass that down to the clerk. You should have before you the draft minutes of the November 18th regular meeting. You should have been sent that ahead of time, but you should have a copy of it. Remember, when it comes to minutes, we don't update. In other words, if something's said in the minutes and events proceed, we don't correct the minutes. The minutes are corrected for accuracy as of when the meeting took place. So please check them over and see if anything in here is wrong.
Move to approve.
Mr. Chair,
Yes, sir.
a small detail, under the absences, I was absent, I'm not listed. I'd considered an excused absent, I was at legislative training away from the building.
So up at the top under absent, please put Representative Edwards, parentheses, excused.
Mr.
And I
Chairman.
think Senator Gray moved to accept. Second.
Okay, so moved by Senator Gray and seconded by Representative Merchant
Edwards.
Edwards.
But I have a point of order.
The minutes with the change at the top for absent. Point of order, Representative Merchant.
Thank you, Mr. Chair. Given the fact that I wasn't here for the November meeting, should I be abstaining, or what action can I take on these minutes?
Probably abstaining because you would have no way of knowing one or the other. Senator Gray.
Robert's rules would allow you to the best of your knowledge, that this is what happened. I don't know whether this committee is operating under Roberts as the Senate does, or under their own rules, so, but
And House rules generally don't allow abstentions, so you're stuck in a quandary, and I think people have done it both ways in the past in the committee.
As many of you know, my style here is try to build consensus, and I think in my 2 years chairing before, we only ever voted once, and I'm really not sure this is going to make much of a difference, so whatever. Which is kind of Pearson's rules. Okay. Any other corrections that need to be made? We'll give you another minute or so.
And Mr. Chair, I just want to remind you, I have to step out at 10:43 for another meeting.
At exactly 10:43 with military precision.
Yep.
Thank you. And I know Representative Merchant has to Zoom at 11, so. Are we ready on the minutes? Okay. All in favor?
Aye.
Opposed? See, that's the workaround. It's a voice vote. We don't know how you voted. Okay.
Actually, I wasn't here then either, so.
This is true. I was, and I still don't remember it. So, just a little, for those of you who are new here, how we usually have our meetings. Usually they are on the fourth Friday of the month at 10 o'clock. On occasion, when that's a holiday weekend, it is moved to the third Friday and it has been at 1 because a couple of members have a morning event on the third Friday. So count on, unless there is a change, count on the fourth Friday. We'll be meeting on the fourth Friday of February at 10 o'clock. What usually happens here, besides the roll call and the approval of the minutes, is we have a wonderful event that I nicknamed Learning from Lori. And that was when Lori Shibanet, the commissioner, would come in and give us an update. I saw no reason to change the title, so we will start with Learning from Lori. And that may go for, some of us hope quite a long time. We'll see. But she is the interim commissioner. Then after that, different reports are given. If you remember, when we vote on bills, it will say such and such a committee is established, and they are to make an annual report to DHHS Oversight. So we will hear numbers of those reports. And then the final thing that can take place is something special, something particular. That is to say, we are wondering about something at DHHS, and so we would like to bring in an individual to talk to us about that. Or sometimes somebody over there, it's not a regular report, but there's something they'd like us to know, and they get on the agenda. So if there's something you would like to know about, let me know, and we will make sure that we schedule this for an upcoming meeting. So that's kind of what we do here. Any questions on that? Seeing none, learning from Lori. We welcome Interim Commissioner Lori Weaver.
Good morning, thank you. I was waiting for a question if there'd be CEUs given out after learning with Lori.
I assume that.
Thank you for the opportunity. I am Lori Weaver, the interim commissioner for the department. Just a little bit about myself. I have been with the department for 25 years in different roles, last 3 years as the deputy commissioner, prior to that an associate commissioner, and prior to that in various director roles within the department. So I'd like to think that I know the department fairly well. However, in the last 6 weeks, I've learned a lot of things that I already didn't know, and I've been there a really long time. So I'm learning as well. Learning with Lori, that's right. I thought for this morning, the update would probably be most appropriate to sort of lay out for you some of my vision for the upcoming year. As interim, there's never any guarantees of how long I'll be in this role, but I will just look forward to the year and set some goals and benchmarks. And I wanted to share with you today what we were looking at doing. And part of it is not being able to do a strategic plan in a year is really challenging, but what can we do? And we can do some planning. So I will be introducing to the organization, I haven't fully done it yet, it's coming up next week, talking to all of the staff, what I'm calling a roadmap, a 2023 roadmap for HHS. So it's basically a high-level plan that we are going to put forth 4 commitments within the department that we are intentionally focusing on and will guide all of our work against, and hold ourselves accountable to those commitments over the upcoming year. We will be sharing progress with this committee, with fiscal committee, with any other committee as appropriate, as well as external stakeholders, how we're doing and where we may need to be improving. So at a high level, I can share with you our commitments. There's 4 of them. And the first one really is investing in our workforce and our culture. Just like many other sectors, we are hurting from a lack of staff. So I really want to focus on building up that workforce, not only hiring people, but also increasing retention rates. Why do people stay, getting them to stay, and then obviously working in our culture. So we'll be spending quite a bit of time on that, setting some goals for where do we want to be at the end of this year. One of the second commitments is managing our resources effectively and efficiently. And this is really about aligning up all of our internal operational pieces so that we don't have a lot of duplication, and to ensure that the resources that we do have are targeted on the things that are priorities for us. So as you probably know, the department is really large and we have a lot of things happening all of the time. And if we could align and strategically resource those appropriate those resources to the priorities, I'd like to be able to see us get farther along in this upcoming year. So that's really, if you think about a project governance structure, it's really our leadership looking at everything that comes in from above, below, and from side. Is this something the department's going to do? We need to see how it aligns with our priorities, and do we have the resources to do it, at least for this first 12 months. And kind of hand in glove with that is what we call enhancing organizational value. So for what we are doing, how well are we doing it? So it's really about metrics, and it's really about working with our partners to make sure that what we spend our money on and what we're intending for an outcome or service, what population are we trying to help, is that contract or that service showing us those results? And if not, how do we align that? So we don't get to the point where we've contracted and spent a lot of money, but we don't have the results. So we're really going to be focusing in our division of quality assurance to hone in on that. And then our fourth commitment is internally related, but it's also externally related. And we call it promoting thriving communities. And that's really about looking at making sure for those services that it's the right service for the right individual at the right time. So you might say, well, what does that mean? Well, we could look at initiatives like our children's system of care model. We know that we spent a good amount of time and money building up that infrastructure, and we have it, but we also know that our utilization is low because we don't have staff in those programs to staff it. So we have children backing up in hospitals that could be discharged, but they don't have a place to go. So it's really looking at that, as well as like juvenile justice transformation and moving to a restorative model rather than a punitive model. So there's a couple other pieces in that. But my promise to you would be that once I have all of those goals and as identified and outcomes, I will be sharing that with you. I need to share it with my organization, my workforce first, and that's coming up in the next 2 weeks. And this was developed just to bring clarity. This was in terms of my vision of what I was seeing in the 12 months that we needed to do. I engaged all of my leadership team to weigh in and help with that, as well as the boots on the ground, the people that are going to be doing this work. So that's we're at the point now of finalizing all of that and getting ready to launch it. So I thought that was probably helpful for an update.
It is very helpful, thank you. And Councillor Williams, do you have those handy sheets that you know I love so much, that is the names and positions and phone numbers and everything? Okay, and you can bring some hard copies at the end of the month if you would, please. It's a wonderful sheet. It tells us who all the division heads, department heads are, and about 85% of them come under your committee, and the other 15%, children and family, come under that committee, which I chair. So it's a good who do I call listing. If you don't have one, you're going to get one very soon.
I think Attorney Williams did give us,
Sorry.
I think Attorney Williams did give at our orientation meeting, if I remember correctly, a similar sheet, didn't you, Attorney Williams? I think you did at that time, at the other committee.
Good. For those of you who lose things while standing still, such as me, it's good to have a few extra copies around. I've photocopied 6 of them. I can find 4 of them. I'm proud of myself. Any questions for the commissioner? How many people named Lori are left at DHHS?
The new popular name is Melissa. It is no longer Lori.
Well, I said to Mr. Lipman, you're always Henry. Don't worry about it. Thank you. We'll look forward to updates each month. Thank
Great.
you.
Thank you.
Next on the list is the Child Fatality Review Committee Annual Report. The chair recognizes Trish Tilley. Good to see you again, Director of Public Health.
Good morning, Chair. Good
Proud
morning.
graduate of Hampshire College.
I am
You
indeed.
are.
Thank you. Good morning. It's great to be here. Thank you so much. So I am just going to give a couple of brief introductory remarks and then actually bring the people who actually do the work to present the report. Our New Hampshire Child Fatality Review has been around for decades with the purpose to identify and collect data about the cause and manner of child deaths, and importantly, to provide prevention recommendations based on that data. In New Hampshire right now, I'm going to cut to the chase and tell you that the top 5 causes of unintentional deaths among children, and that is age 0 to 21, include overdose deaths, accidents from ATVs and snowmobiles, motor vehicle accidents, drowning, and blunt force trauma. Equally concerning is that suicide is by far the leading cause of intentional deaths. Suicides by hanging, suicides by firearms, suicides by poisonings. Between 2017 and 2021, there were 93 suicides of youth up to age 21, each of them heartbreaking, each of them leaving a family in grief. So before I hand this over to the team that put this report together, there's 3 reasons why I think that this report is important. One, it's powerful. It's data driven. And I think members of your policy and finance committees, it gives you the information that you need as you think about your own priorities and as you think about policy setting for the entire state. Number 2, the focus is on prevention. While we are lucky that New Hampshire's child mortality rate is well below the national average, 1 preventable death is too many. So this is, we understand deeply that 1 grieving family is too many. And 3, this report is a reflection of partnership. It is not the department's report. This is the report of a committed group of community-based individuals, doctors, epidemiologists, behavioral health specialists, on, prevention folks. They have all reviewed this data, and they have had robust conversations about what we can do better. Everyone on the review panel is committed to the notion that preventable child death is a collective problem and that solutions can be found in the community as well as in our homes. So I'm going to hand it over to Rhonda Siegel, Mark Clement, and Joe Porter, and they're going to walk you through the report, if I may. Thank you.
You may. Thank you. Question from Representative Edwards.
Good morning.
Good morning. You know I can't let you get away without at least one question, right? I skipped ahead. The recommendations pages on 6 and 7
Yes.
sing to me. What would make it really great is to know, is there a specific recommendation where you think legislative action is required? And can we highlight the recommendations for which you would expect some legislative support?
That is a great question, and it's a great idea. So when the committee, and they can talk more about it, the chairs of the committee put together those recommendations, I think they can speak to whether or not they feel like some of those rise to the level of policy interventions right now. Many of the recommendations are really community-based recommendations. They're things we can do now, things we can do with our partners. But I'd love for the 2 chairs of the committee to weigh in on that and take that as a note for the next time we prepare the report to be able to highlight that right up front.
Thank you.
Representative Murphy.
Thank you, Mr. Chairman, and thank you for taking my question. I'm assuming you mentioned intentional death. I'm assuming that the great majority would be suicide.
Yes, 88% of the intentional deaths are suicide. The others are homicide.
I was going to say, so the other bucket is basically homicides, and
Correct.
that was what I was going to get at, the number. I wasn't really aware of how many homicides. 12%, as you're saying?
Yeah, it's just about 12%. I'm sure I don't have the report. I didn't bring the report up with me to give you the exact number, but by far, again, suicide is the leader of the intentional, but we have had homicides in that age group from 0 to 21. It's very concerning.
Wow, thank you.
Yep. Thank you. All right, so I will hand it over to this group. Thank you. And they are aware that we're supposed to move quickly.
Mr. Chair, just so you know, there's a significant number of people out in the audience that are going to want to go down to Division 3 at 11 a.m. That's I think.
Do they want to go or are they just going?
No, they've been
They
compelled.
want to go. Okay.
Compelled. Yeah.
Yeah, they look like it. Yeah. And would you give us your names slowly for the clerk, please?
Good morning. I'm Rhonda Siegel.
Could you spell that, please?
Excuse me?
Could you spell that,
Sure.
please?
Rhonda, R-H-O-N-D-A. Siegel, S-I-E-G-E-L.
Thank you.
And then I'll let my colleagues tell you their names, and then I'll...
Good morning. I'm Joe Porter. I'm with the University of New Hampshire, and I'm a co-chair of the Child Fatality Review Committee.
Joe, J-O.
J-O.
Porter.
Porter, P-O-R-T-E-R.
Oh, well, all right. I grew up in Greater Boston. Porter.
And I'm also co-chair. My name is Mark, M-A-R-C, Clement, C-L-E-M-E-N-T.
Thank you.
Thank you. Good morning. It's nice to be here again. My name is Rhonda Siegel, and I'm the Section Chief for Maternal and Child Health within the Division of Public Health Services, under which the administration of the Fatality Review Committee and its two subcommittees, Sudden and Unexpected Infant Death Review and the Sudden Death in the Young Review, reside. We actually just came right now, a combined SUID SDY meeting is taking place. RSA 13241 established a Child Fatality Review Committee whose function is to answer the following two questions. What could have been changed that would have prevented the death? And what changes are necessary to prevent future deaths? So for SUID and SDY, we review all deaths in the state. However, that's not the case for child deaths. We select cases based on data trends as presented in the report, and we work hand in hand with the Office of the Chief Medical Examiner, who is is a vital partner. For state fiscal year 22, which this report is about, in the larger Child Fatality Review Committee, we focused on suicide and motor vehicle deaths. We reviewed 8 cases in 6 meetings. My colleagues are going to tell you a little bit about what we do in those meetings and talk to you a little bit about recommendations.
So thank you for the opportunity to talk about the New Hampshire Child Fatality Review Committee. As mentioned, my name is Mark Clement. I'm a child psychologist, a retired emeriti Colby Sawyer College faculty member, and I still teach part-time at New England College. Let me give you some background on child fatality review teams. The New Hampshire Child Fatality Review Committee was inaugurated by executive order of Governor Judd Gregg in 1991. The committee was restructured in 1996 by a subsequent executive order of Governor Merrill, which placed the committee under the auspices of the Department of Justice, where it remained until 2019 legislation which placed us under the Department of Health and Human Services. Now, I've served as chair or co-chair since that 1996 restructuring. The committee published and sent to Governor Shaheen its first annual report in October of 1998, and I know you have our most recent annual report. Now, every state in the United States has a Child Fatality Review Committee. They all function slightly differently. New Hampshire has a single team. Most large states have multiple teams, like Massachusetts, Michigan, New York, et cetera, and an overarching state team. Some teams only review child abuse deaths. Some have large budgets, large staff dedicated to just child reviews, child fatality reviews, and there are multiple of other differences. There's a National Center for Review and Prevention of Child Deaths based in Washington, D.C. They provide guidance, educational material, and national data to the state teams, but they have no control over our review committee and how we operate. Okay, we do our work in ways that we feel are best for the protection of children in New Hampshire. My role today is to help you understand how the committee does its work. As mentioned, there are 5 objectives for the committee listed in our legislation. And to synthesize them, basically what they say is that we are to review the deaths of New Hampshire children and generate recommendations that we feel will reduce the probability of children dying from these other causes in the future. We have a committee of 28 highly placed and highly qualified New Hampshire professionals who represent virtually every public and private agency that is working with and for children. Our membership is designated in the legislation. We meet every other month to review child fatalities and to generate recommendations. So I'm going to describe to you how a typical meeting is organized and run. But before I do that, I need to make 3 general statements. First of all, our major responsibility is confidentiality. Every member signs a confidentiality agreement that prohibits them from sharing any information that's discussed in the review. Any non-member who comes to the review to present information, for example, a police officer who might have investigated that death, also is required to sign a confidentiality agreement. And I should add that our member representative from the Attorney General's office has been very meticulous in reminding and helping us with confidentiality security. Secondly, we are not an investigative body. We take information that is brought to the committee by individuals or agencies that have information to share about the death. And lastly, we do not review any death that is presently in litigation or has the possibility of future litigation. This is our guidance from the Attorney General. After all litigation and appeals have been completed, we would review that death. We start each of our meetings in a public session where, after some introductions and initial business, we have a presentation regarding data and regulations that are related to the types of deaths we're reviewing. For example, in reviewing suicide deaths last year, we had an individual from the New Hampshire State Suicide Prevention, the New Hampshire State Suicide Prevention Coordinator, come and give us a presentation about suicide deaths in the state of New Hampshire. Our last review a few weeks ago, we reviewed the deaths of children who died in fires. We had members of the Fire Marshal's Office do a presentation on fire deaths in New Hampshire and fire safety regulations. The purpose of these presentations is that everyone on the committee aware of what the latest regulations and data are for that particular type of death. At that point, after the presentation, we go into a non-public session, and any members of the public who are present are asked to leave the room. Information about the death is then presented by any individual or agency that has information. We typically start with law enforcement, then the chief medical officer, DCYF if they have any information, EMS, any routine or non-routine medical information, behavioral health, and then anyone else who has any information from their agency. We then open it up to any questions that members have about that information. Once all the questions are answered and all the information is presented, we move on to the recommendations part of the review, and this is where our co-chair takes over.
Dr. Clement, because some people have to leave, Chair calls on Representative Edwards with a question for you.
Thank you, Mr. Chair. I appreciate your discretion, and apologize in advance for just jumping to the middle right away. I'm looking at page 6, recommendation 2, support healthcare provider practices reviewing firearm safety at well child visits. And then the implementation activity, firearm safety is reviewed as a routine part of anticipatory guidance in pediatric and adolescent well care visits as per Bright Futures guidelines. I just want to share with you a very heated conversation I had with a constituent that was representative of other constituents' attitudes. And they are incensed when a doctor asks them the status of firearms in their home. They don't think that's any of their business. It's not part of what a typical patient-physician relationship ought to be. The request was, can you please submit legislation barring the question being asked? And of course I said, no, that's a First Amendment violation. We don't want the legislature crawling in between the physician and the patient. But I just want to know if this second bullet implies that it's becoming best practice among pediatric physicians to make inquiries about the possession of Second Amendment rights in a home.
I think I'm going to let. Yes.
It is best practice because storing those firearms safely is a best practice. It reduces risk. So it's
I'm
commonly.
sorry to be interrupting. I just really do have to go.
Oh, yes.
But people who own firearms don't typically go to their physician to ask about how to safely maintain a firearm.
It's anticipatory guidance for kids, for adolescents and children.
Okay, I just hope as you all roll this out, you remain extremely sensitive.
Yes.
That this is not an area where people want their physicians crawling up inside their households. So I do understand the other side of it, though. We don't want kids crawling around and finding a gun and there being an accidental shooting. But that's what responsible gun ownership does.
Yes.
And if there is irresponsible gun ownership, then those people aren't going to be listening to the physician given guidelines anyways in most cases. So if this is a New Hampshire best practice that we're trying to roll out and implement, it would give you a huge cautionary note.
Representative Weber, to this point?
To the point, I was just wondering how many accidental, because I'm having a hard time just shoveling through and finding the right chart. I know they're all in there, I just haven't found it yet. Could you just point us to the statistics on that inform this as a concern, so we know how many incidents we're talking about?
Not many, as Director Tilley
Okay.
told you about initially. I mean, New Hampshire's child fatality incidence is fairly low.
Okay.
The intentional part of that is suicide, most of which happen with firearms,
Okay.
including with teenagers. Homicide, unintentional firearm deaths are very rare.
Okay. Thank you very much. Thank you very much. I appreciate it. I just wanted to be sure that there was a reason for that issue being highlighted.
Is it to this point, Representative Murphy?
Yes, it is.
You may speak.
No, I was just going to point to the fact that on page 17, 38% of all intentional deaths are secondary to firearms. And I think that question that Representative Edwards brought up is important, but it's also to recognize also that in all well child checkups, in all pediatric checkups, they're not specifically only asking about firearms.
Correct.
They're asking, one of the leading questions is always, if I'm, and I've been with my grandkids and my kids, it is, do you feel safe at home? And they're trying to probe not only their environment where they live, whether there's a gun available or drugs available. There could be the same question. They're also just asking, do they feel safe at home? So I think this is reasonable to ask the question only because it is part of the global question: are you safe at home, and do you feel endangered by any means, by virtue of yourself or another person in the household?
Yes, and that's what anticipatory guidance means, just asking a ton of questions about health and environment.
And for the record, Representative Murphy is Dr. Murphy, so you speak from experience to this subject.
Yes, but I was assuming I was speaking as Representative Murphy, but with a background in medicine. So
You may speak out of both sides of your mouth. We all do.
I've done that often, Mr. Chair.
Yes, sir.
Thank you.
The department may continue.
Is there another question? Are we good?
The question I was going to ask was answered. Thank you.
Just wanted to be sure before I jumped in. Okay. Well, thank you. I also wanted to thank you
But
all
for the record, the chair will recognize people
Oh,
who wish
sorry.
to speak, and if the chair misses it, which he often does, you can just sort of point and wave, and I will not be offended.
Well, thank you for the guidance and the opportunity to discuss the commission's work. As my co-chair mentioned, I'm going to talk a little bit about the process by which we get to the recommendations that you see in this report. I think one of the things that I didn't anticipate in my comments, but I will mention here just because it's part of the discussion, is that there's probably many recommendations this group would bring forward, but the ones that you see are related to the course of the time that we were together in fiscal year 22. So while that that recommendation around anticipatory guidance around firearm safety exists in this report, we've had previous ones around swim safety, around drowning, all part of the anticipatory guidance component. So there's a whole range of pediatrician related well child care visit checkpoints that we talk about. I understand that firearm safety sort of jumps off the page in this particular report, but in previous reports you would see things that were also related to accidental deaths as part of anticipatory guidance that would show up, that would be additional topics. So you're seeing ones related to the cases that we've talked about in this year. But it sits in the scope of a broad range of items that we've brought forward as recommendations as a committee. So I just wanted that to be in context, because I know it sort of feels like there's a singular topic that's brought out, which is true because it's reflective of the cases that we talked about in this set of conversations. But if you looked at our history, you'd see a whole host of anticipatory guidance related items. And all of that comes from the reality that when we review these cases, as Mark mentioned, our goal is very much to better understand the circumstances of that case, not because obviously we can do anything about that case, but we want to understand how we can learn from those cases for additional recommendations for both prevention and promotion of positive activities. The way that we do that is we shape those conversations around risk factors and protective factors, oftentimes despite the outcome of the case. There are lots of historical components of a child's history that bring forward some things that could be protective, and we want to highlight those in addition to the risk factors that that led to the outcomes that we're seeing. So we talk about those potential points of intervention to prevent future child fatalities. We typically have a conversation about what the risk factors were across the cases that we reviewed and what the protective factors are. And what you can see is that within the specific recommendations of the report, they often come into themes. So many of those themes are around increased awareness, that's often of resources and services. What we have found in these reviews is that there's often a lack of public knowledge of some of the resources that might be available to children and to families. So we want to bring those forward as much as we can. That includes examples in these cases that we reviewed around 988 as a mental health service and distracted driving campaigns. So when we've talked about the motor vehicle accidents and we've talked about the suicides, we've seen these, what our, as Mark mentioned, very well-rounded set of organizations around the table understand that there are resources that may have been beneficial to certain families in these cases. I'm trying to get information out to make that awareness as great as possible across the state. Community partners, again, around resources that are available to professionals that are interfacing with the families, as Mark mentioned. So you'll see a number of recommendations for better leveraging those healthcare professionals or those service professionals to serve as dissemination points of resources to families as well. There's a number of times that we talk about just strengthening the systems of care. I know Commissioner Weaver talked a bit about the workforce shortages that we have. We certainly see that resonating in the outcomes in some of these cases where there's maybe services that could have been available for folks, but they may have had trouble accessing those. So strengthening the systems of care comes forward a number of times. We also have recommendations around processes and procedures. We've learned about how sometimes the communication points across the organizations that are touching families maybe are not communicating with each other, and those become potential points of intervention. And then we also have, for our own work and the work of understanding child fatality better, you may also see some recommendations around better collection of information that can serve to inform our work and obviously the work of reviewing fatality cases overall. So those are kind of the general themes that I think that we landed on in the last couple of years of work. I've only been in the co-chair role since 2021, so there's probably a whole host of work before then that we could reflect on, but I'm not in the best position to talk about that. And then I just wanted to mention, and Representative Edwards mentioned it, sort of after the recommendations are created out of this committee, then we work with the department's team Lisa, who's here, and Rhonda and others, to really think about how to implement those recommendations. So what we don't want to do is sort of end with, well, this should be better, and be done with it at that point. And so we meet and talk a little bit about not only what should the department be doing, but honestly, there's a lot of commitment among the organizations that sit around the table to think about what their role could be in helping to move some of these recommendations forward. So that could include a recent conversation that we had where a representative from the hospitals indicated that they feel like there's some training that could be done in the ER staff. So we're talking with them about ways to potentially bring that forward. So that kind of implementation work doesn't necessarily get captured in the report because it's a sort of multi-step project that happens after that. But certainly there's a whole host of implementation activities that come post those recommendations coming out of the committee. So with that, I will stop because I know we're short on time and answer any questions that I can.
Representative Murphy.
Great. Thank you very much, Mr. Chairman. This sheet is great. I mean, it's got a lot of detail, and I haven't absorbed much of it yet. But I had one thing struck me is a couple things. On unintentional deaths in age 1 to 21, poisoning with opioids was 38%. That's a huge number. If you look at the next page, 17, and it looks intentional, suicide deaths, it's only 1%. It's opioids. So that means this 38%. I'm kind of curious as where do they get the drugs now? Is this drugs at school or on the street, or is this going through the parents' cabinets? Do you have that broken down as to where they get those drugs in that 38%?
So we don't have it broken down in the report, but poisoning, you're right, does include overdose deaths. We could provide that information for you.
So, follow, Mr. Chairman?
Follow up.
So the reason I ask that is I'm kind of a double-edged question here is what would this have looked like, say, 5 years ago? That 38%. Was it 38% 5 years ago? And the other part, the reason I ask that is if the children are getting their drugs out of the cabinet from parents, several years ago, we used the pain as the fifth vital sign. And so we really were prescribing heavily opioids. And I'm wondering if that's a residual of having a lot of drugs in the house versus picking up in the street. I'm just trying to understand where the opioid deaths in the use of drugs comes from, street versus home.
Most of the opioid deaths in teenagers do not come from something that they found in their parents.
Right, but
so they come from either purchasing it illegally. That being said, I don't know the specifics. I can tell you we in maternal and child health have something called the National Violent Death Reporting System, where we put together all these factoids. I do know, because I've been around a long time, that 10, 15 years ago, motor vehicle crashes were number one and not poisoning. So there's been a very definitive change in the last 10, 15 years or so.
And just one
One more follow up.
And yeah, because I remember that 15 years ago, that was the leading cause was, trauma, so in your chart says ages 1 to 21. I understand the teenage group, but I'm just kind of wondering how many of those are 1 to 10 and is it at home that they get them? And if I might ask just one last question, on page 14, you list under natural causes, there are 2 that are homicides. And I'm just kind of curious as how homicide gets into natural causes of death. On page 14? Or is...
I will have to find out that answer for you.
I'm just curious more than that.
Yes.
Thank you. Thank you.
Representative Weber.
Thank you, Mr. Chairman. Thank you all for being here. It's good to see those of you who I already know again. I was just wondering, with respect to the motor vehicle deaths, has the percentage changed? I assume that the percentage has changed because opioid deaths have gone up, but have over that period of time motor vehicle deaths gone down, or are they staying the same? if you know.
It depends upon the year. Luckily, in New Hampshire, we're a very small state, so the numbers go up and down. Motor vehicle deaths, in particular, fatalities, have gone down because of a variety of reasons. Seatbelt use, the very cool way that a car works to keep you safe in the event of a crash.
Representative Merchant.
Thank you, Mr. Chair. And thank you for taking the question. Following up on Representative Murphy's question about the accidental suicides by opiate, I think it was 2 or 3 years ago, we passed a law that the pharmacist has to put an orange label onto an opioid when it's dispensed by the pharmacist. It'd be interesting to go back over time to see if that's actually had an impact on reducing the rate, if you will, or whether we're just putting something on the sticker on the bottle, but in reality, it's not truly having an impact. Is there a way for us to go back and look at the timeline?
I don't know, Director Tilley, the prescription drug monitoring program is in our division, and I don't know if that would be the most appropriate section or program to.
I am sorry, Representative Merchant. I was having a sidebar conversation while you were asking your question. If you could repeat that for me, thank you.
Sure, thank you. 2 or 3 years ago, we passed a law that required the pharmacist to put an orange sticker saying it's an opiate onto the prescription if it had an opiate. I would like to find out over time what impact that's actually had on preventing households or children getting into the opiates, or somehow looking at how that law has truly impacted one way or the other, how suicides possibly with children are occurring.
Sure. So I think we would have to look at a couple of different data sets, as Rhonda was saying. We could look at our PDMP, and I'm sorry, I can't see you because there's a fan right in the way. I feel awkward about that, but thank you. Thank you, Mark. So I think we'd have to look at a couple data sets. We'd have to look at the PDMP, so we'd see the rate of those prescriptions. The child fatality review could go a little bit into the death report and sort of understand, as you know, we look at page 16 with those accidental deaths and the poisoning of opioids. You know, we can see that there was one case, again, this is over several years, 2017 to 21. There was a case among a 1 to 4 year old. I think we can all be pretty confident that the 1 to 4 year old did not do that intentionally in any way. And then we only had another case in 10 to 14, and then a handful of cases among 15 to 18 year olds. So I think we would have to look at our two data sets, what's in the death record. We would also have to look at PDMP, and then I think there would have to be some conjecture about how those two are related. I don't know that we can do a direct correlation or a direct causation from the orange label to a child getting into it.
Understood. Thank you. I think at that point in time, if we can at least look it over a timeline.
Yes, we
Thank
can
you.
absolutely do that. Thank you.
We can do that. We also can, the administration or the oversight of the Poison Control Center is also within MCH in our division. So we can ask, oftentimes they're like the canary in the coal mine. And so they also collect poisoning stats, and often the first ones, both that citizens and actually pharmacists and healthcare providers call.
My mind tends to think synthetically, and I love to bring this, and that one or groups together for a groupthink. Yesterday, I was talking with the director of motor vehicles, John Marasco, about where do we go next in terms of this card for deaf motorists that was developed in the New Hampshire Commission for the Deaf and Hard of Hearing. I could also see conversations with the various gun groups in New Hampshire as to how best we could encourage people for safe gun storage that will at least partially get the word out, especially where there are physicians who do not ask this question of their children, whether they should or not, they do not. And it is for reasons we can guess. How can we bridge the gap? So my suggestion is, as I plod through this wonderful detailed report, I know where my mind will go. Hey, right here, this group should be talking with you folks. I would encourage that. I find that's works, and I find that it's probably in some ways already being done. Yes.
Yeah. Yes, absolutely. I mean, that's really the power of this group, is to bring together those coalitions. In your note, in the conversation around safe gun ownership, there's an example that we've had in New Hampshire for a long time around the gun shop project, where gun shops really took some, looked at some education and worked with folks around suicide prevention in adults. So there, and that is an example of where we've taken folks from the public health world and the medical world and, you know, responsible gun owners to have a conversation of, because no one wants to have a suicide or an unintended death that's related back to a particular firearm.
Thank you. Any other questions? Seeing none, thank you so much. Thank you so much.
Thank you.
I've been texting various ones out there to see if they wanted to bring us a few things, because we have the time. And Paula Minahan from the Hospital Association wants to talk to me about some things afterwards. And that includes Mr. Padmore. That's afterwards. Okay. And did I see Henry Lippman out there? Yes, I did. Not named Lori. Mr. Lippman, come on up and say some things about Medicaid, because we will be looking at that in the legislature this term. So I know it's off the cuff, but you have good cuffs. So
Thank you, sir.
you're welcome.
Good morning. For the record, Henry Lipman, the Medicaid Director, Lipman is how you spell my last name. I think there are a couple things I've been trying to bring to the attention of the committees of jurisdiction over the past week or so. Probably most importantly, where you might be hearing from your constituents on is the Consolidated Appropriations Act that was passed at the end of the year, which decouples the continuous enrollment from the public health emergency, declared federally. We're starting to notify individuals first with a heads up letter that has gone out over the past week or so, to let them know that if they've been in the protected status, meaning that they haven't completed their redetermination of eligibility, that they run the risk of losing coverage. And the department had a meeting with CMS to review our unwind plan with them, and it was an informal meeting. We got enough of an indication that we're in the right place with that, and submitted our plan on the 1st, which was required in order for us to start the unwind starting April 1st. There are about 102,000 individuals today that are in that protected status. The largest group is our individuals in the Granted Advantage program, about 47,000 individuals there. The next largest group is actually children, a little over 35,000. In our unwind strategy, and if I'm going on too long, please give me a signal, but if this isn't good information for you. But the strategy that we're taking, because we have to spread the review of eligibility over 1/9, meaning of our total enrollment today, which is about 250,000 individuals. We can only do 1/9 of them per month. And what we're trying to do is look at first those individuals that we've lost contact with, and those individuals who, from a claims analysis, have not used services. And what we're really doing is a risk-based strategy, so that individuals that, for example, we know are residing in a nursing home, or have underlying medical conditions, we're going to allow ourselves more time to get to those people, so that we're not, my main goal is people who should remain on coverage, that we're trying to do our best we can to make sure that they do, and those that aren't going to be eligible, to make them aware of what their options are. Just last Friday, the federal government announced that there'll be a special enrollment period for individuals who are losing Medicaid coverage. And in fact, they allow, which is a little bit unusual, before they even lose coverage, within the 60-day window before they lose coverage, they can sign up, so there would be potentially no break in health coverage. So there's a lot of work going on behind that, and I want to keep key stakeholders informed of what's going on, because I'm sure you'll hear from constituents, and if we're missing something, we want to hear, you may be a conduit to share something for us to correct or to make right. The other major initiative is we're coming towards the 4/1 deadline of implementing the adult dental program. We've made good progress there. We submitted all of our state plan amendments and waiver amendments that were required to implement it as required under legislation. We believe that we'll be through that process on time. My only concern, I think, on that is, with all this going on at the federal government level, would they potentially fall behind with what they need to do? But I've reached out to the top of the chain of command there and let them know that how important this is, and I've gotten an indication they're going to help us get to the date that we need to. We have entered into a contract with Delta Dental, who will be the entity that will be providing the coverage. The biggest thing in front of us is building out the network, and that is, over the next month would be a good thing to report on to the next committee meeting, because that's sort of the key thing we're working on. It's not as far along as I'd like to see it at this point, but we know that it's the most important thing to get done. I think in terms of the other major bill that I think, on a forward-looking basis is the reauthorization of the Granted Advantage program, which would otherwise expire December 31st of this year, if there's not an action to reauthorize. Today, we're covering approximately a little over 95,000 individuals on Granted Advantage. Of those, our forecast at this point is probably by the time we do the unwind, it'll be closer to 64,000. We began the pandemic at about 51,000. The Granted Advantage is a program that's basically an income-driven eligibility. And what we're seeing, there is, I think, that across the state that, the beginning of the federal public health emergency period in March of 2020, that, when there was a high sudden increase in unemployment, that, many people were able to gain coverage this way. They're also good candidates potentially to be able to move to the marketplace. So I think that's that topic. If there's a particular area that you'd like me to address, I'd be happy to do so.
Representative King.
Yes, thank you, Mr. Chairman, and also thank you, Mr. Littman, for taking this question. I met with a constituent just this morning, and he's very concerned for his mother-in-law who had long-term insurance, long-term care insurance, and that didn't seem to really do much for them. And now Medicaid is telling them that they had to actually cancel that policy, which they've now done, and doesn't give them any options. She has no money, and yet she can't actually be put into a home at this point because she hasn't gone through all the qualifications on where Medicaid's going to be. What kind of advice do I have to give to him?
So I think the best thing, because these things can kind of get complicated, is if you share the person who's representing a relative, be happy to have someone reach out and call and try to help them sort it out. the process in New Hampshire, one piece of legislation that didn't get through last year was one where it was part of a larger bill, but today we have to do asset verification for looking back to 5 years. Sometimes when we're doing that process, we can see that maybe looking back 3 years as an example, that there's enough information that you can make a reasonable assertion. I think there's sort of a double edge here. On the one hand, we're trying to protect the state from paying for services that they shouldn't. On the other hand, we're also trying to protect the person to make sure they're aware of what their financial responsibility may or may not be. It's working with the team within the department. We're always here to try to help people. Sometimes it's hard in terms of being able to pull together financial documents and the like, but our team's very willing to help. So if afterwards, if you don't have my phone number, or email address, I'll provide that to you.
I do have it, and thank you. And I will be reaching out.
Great.
Thank you.
Let me pick up on that very point on asset verification. I know sometimes on assistance programs, always the question of means testing comes up in case somebody wonderfully gets an employment that now they don't need the program. You were pointing out, on the one hand, the responsibility to the state, on the other to the individual. And on Granite Advantage, do you means test? If so, what is the way you do that?
So the Granted Advantage is purely an income test, is not an asset component to that. And that's because of federal standards on that. But we have mechanisms to be able to check people's earnings that sign up into the program. Generally, self-employed is a little bit different situation, but people have a responsibility to report a change in circumstance. And if their income changes, they would potentially no longer be eligible, and that would be, and I could just share with you that in part of our, New Hampshire never stopped doing eligibility and people who voluntarily did their redeterminations, but since June, we've been able to get over 31,000 individuals through our outreach to complete their redetermination on a voluntary basis, and that's an updated number from this morning that I received. And over 1,700 people who we've reached out to have told us we don't need Medicaid anymore. We've got another source of coverage, so we've been able to save the state money by doing that outreach. And I think probably by next week, if I came in, it'd be close to 2,000 because we're working lists where we might get a referral from one of the MCOs saying this is what they said, but we have to verify that internally before we act on it.
Thank you. Representative Weber.
Thank you both. I'm thinking of a couple of things that have come up to me. As a follow-up to Representative King's question, obviously he has somebody who's already in difficulties, but I've had several people come and ask how they get qualified because they're helping an elder or a friend or somebody through the process. And I have offered a number of suggestions, which range from 211 to Service Link to going down to the the department office in Keene. Do you have a preferred way or a way that you know of that's the best for somebody, or does it depend entirely on an individual's circumstances?
I'm feeling Chris Santinello's.
Because you'll be glad to know I'd rather not refer everybody to the commissioner's office.
So thank you, Chris Santinello, Associate Commissioner. Henry and I work really closely together for this. I think, honestly, service links right now would be the first choice just because our staff are so busy right now working on the unwind, doing outreach, making sure those that have continuous enrollment, we get through that. Second choice would be coming to the district office. Because lots of times, if someone comes to the district office, our staff at the front desk can answer questions, provide them information. So I would say Service Link or coming into the district office.
Okay, thank you, because I will just pass along that anecdotally, Service Link is pretty inundated as well.
I know.
And I know I'm not telling you anything you don't already know, but I'm just reiterating, which.
Totally agree. And again, you can just reach out to me if you have any
And
questions.
may I ask
Please,
another couple?
please do.
I'm thinking of a fellow representative and director. He may have reached out to you already, but has constituents who are ophthalmologists who take Medicaid and very concerned because there are unpaid invoices 6 months out. And I'm wondering what's happening with that.
So a representative did alert me to that, and gave me the phone number to the practice in question, and I attempted to reach out to them. I understand they're away probably till next week, so we haven't made direct contact yet, but we'll certainly help them out.
Thank you. And, it's of concern because, of course, as you're building out the dental networks, providers that take Medicaid are thin on the ground, and we want to keep the ones who are providing the services.
So generally, there is a requirement that we monitor in terms of timely payment of claims, and there are penalties if they don't do that. I think with that particular circumstance, with the information I have, there may be a little bit more to it than that.
There may well
Yeah.
be, and I just want to again bring it up as a concern, because generally, although it may be one specific set of circumstances, the lack of providers is nothing new as a concern to every person in this room. So thank you very much.
Chairman McDonald.
Thank you, Mr. Chairman. This is just a knowledge update question for myself. Service Link, did that take the place of New Hampshire Easy?
No, we still have New Hampshire Easy. So Service Link, and I was actually, as before you asked the question, I was thinking, I should have said New Hampshire Easy as well.
Okay.
But yes, we still
Okay.
have New Hampshire.
Yeah, I was wondering. Okay, thank you very much.
You're welcome.
Few questions from me, picking up on previous questions. I think most of you know I am part-time CEO of a faith-based wellness center in Kingston, and taking Medicaid patients is part of what we want to do. I also have to pay our bills, and I'm wondering when we will see a good increase in what providers receive for taking Medicaid people by my family practitioners.
So the department and the agency budget phase made requests. There's also a number of bills, the largest of which I think was written up in the news this week, Senate Bill 86, which proposes to add 145 million in rate increases over the biennium. And the first hearing on that was last week.
You're throwing it back to me, and I'll take it.
Yeah, sure.
Thank you.
I think this is one of the major issues that I'm sure that this legislature will have to deal with this session, is how to, that we're sort of, I kind of look at where we're at a little bit like the pressure building up on a dam that has a leak, and how much can it be held back, and that has to be worked sort of through.
I recently had a chat with Tom Raffio from Delta Dental, and I said, how's it going? Because as you know, I was one who took point on the floor of the House on the dental bill.
Yes,
and
thank you.
thinking that it would, please God, by 10, and it passed by 90 something. So there's hope going forward on some of this other stuff. I think I'm doing my work. But he pointed out that, it's all well and good to have the money available, but you need dentists who will do it. How are we doing on getting dentists to take people under the dental program?
So that's, I think, still one of our key challenges for April 1st. We're working just before this meeting. I was meeting with people about that, and I'm going to be meeting with probably Tom Raffio next week in terms of, and what we can do to build that. We are having some successes, but we're not where we need to be yet. Just going back to the rate increase, if I could talk about that for a moment. Last session, you did pass rate increases, and maybe just remind some of the key ones is ambulances, which we're seeing some challenges. You may hear from constituents about transferring patients between hospitals or between nursing homes and hospitals. That was an increase that brought New Hampshire's ambulance rates from 25% to 50% of Medicare. Still, I think an area of concern from an access standpoint to me as the Medicaid director. We also added 25% to maternity care delivered at hospitals. The 25% was the average. We were able to increase the rates at critical access hospitals that still do maternity by 34% and 24% at the larger hospitals. In terms of other kind of rate increases that, off the top of my head, those are two that comes to mind, but there are probably a couple others that.
Are there plans afoot within the department? I know they're trying to hire. In the medical facility I look after, we have been partially paying students' tuitions with loan forgiveness or tuition forgiveness as they work for us. That is putting another step on a tall ladder that they can negotiate. I also know Rockingham County Nursing Home, because that's my legislative responsibility as part of the delegation. We are doing similar. What could we do, perhaps? Are there plans afoot? For example, to help somebody in a dental school in exchange to come here to help with this population?
We do, and Tricia Tilley's probably knows more about this than I do, but within public health, we have loan forgiveness program or loan repayment programs that are available. In addition, we have been trying to help the county nursing facilities all through the federal public health emergency. We've been passing on the extra federal matching percentage directly to the county nursing facilities in the form of their pro share payments, and in terms of the county cap calculations, helping out the counties with their obligations as well. And it's been a fairly sizable number as it's gone on for almost 3 years. Just one anecdotal footnote there, that the Consolidated Appropriation Act carries the enhanced federal match through March 31st at 6.2%, then is reduced a quarter at a time from 6.2 to 5 to 2.5 to 1.5, where the enhanced FMAP ends the end of this calendar year.
Director Tilley, how are we going to make this better and bigger?
Thank you so much, Chair. So as Henry noted, we have our state loan repayment program, and specifically around dental. We've also expanded it this year to private dentists who take Medicaid clients. That was a huge lift for us, as opposed to in the past, we really had dentists that were in our federally qualified health centers or were that working in one of those types of facilities, but to expand it to private has been a big deal, and we've had good uptake over the past year. We've been using ARPA funds. Those funds will go away at some point, so that's certainly a conversation for another biennium to have, but we have been very fortunate to have ARPA funds and some general funds to provide that loan repayment. And the other piece is we also have a recruitment contract where we're going out and recruiting like crazy.
I know that there's underserved areas, but there are underserved people groups within a well-served area. Are we improving the underserved people in non-underserved areas?
Yes, absolutely.
That's
and that's what we look at. I mean,
personal.
it's a twofer. So there's, and we have a whole bit of alphabet soup, as many of you know, of HRSAs and HIPSAs and DIPSAs and MIPSAs, which are our health professional shortage areas. But we also look at those specific populations, and primarily of them are low income. And so that's where Henry's work and my work always intersect, that we're always trying to make sure that we have access for those who have Medicaid, and especially now as we're looking at the new adult dental benefit.
Your speaking all of these terms made me very grateful. My mom fed me alphabet soup as a child. Representative Murphy.
Thank you, Mr. Chairman. Director, thank you so much for sitting in the hot seat unannounced and without any preparation.
I
Obviously,
texted him ahead of time. He was
I
not
I
totally
understand. Well,
unprepared.
I appreciate that, and obviously it's a hot topic. And you brought up the question of stratification. I certainly appreciate that you can only do 1/9 of the population at risk right now at a time.
Yes.
But certainly, risk stratification as to who will fall off the cliff first and need it. And I was wondering what sort of data you use to determine that. Is it simply their age? Do you have access to their employment currently? Do you have access to their current health record that they may have a need? I was just kind of curious as to where you had that, where that data came from.
So we look at their categorical eligibility. So for example, someone who's in CFI, the choices for independence or long-term care or children, that those are generally the vulnerable groups. And we early on the process, we did a lot of outreach to those, and fortunately those are, other than the children group, is smaller, it's sort of a smaller population. Then we added the dimension of looking at claims that we had as to whether and we basically used a dollar stratification to look at if they had 0 claims over the past year. That suggests they're probably lower risk, not an absolute. None of this is, a perfect science. And then we looked at, certain conditions like someone who might have hemophilia as an example, that, going without coverage could be pretty serious to their life situation. And then we looked at, large people who used a lot of healthcare as being someone that we want to actually do maybe some personal outreach, either directly through department staff or through our MCOs. So, a lot of states are just doing it like first in, first out. And, we're trying to be more sensitive to it. And I'm proud of that we're making it that way.
And just a quick follow-up is if
Follow
you,
up, yes.
Thank you. Given a circumstance, say somebody this year in 23 is just about to turn 65, say in December, but they're going to go off the cliff in April. Is there any way that they can move up their eligibility date for Medicare? Is that coordinated in that way at all to help them bridge that gap?
There are actually, thank you for the question. There are actually people who should be on Medicare that aren't there yet, and those are another sort of group that we want to work with carefully. I think that there are people who could potentially be dual eligible. Before we actually let someone off the plan, we have to run them through what we call our cascade to see if they're eligible for something else. And so that, I know as much as we're planning, and we've been planning for this since July of 2020 on a weekly basis, that we're going to need your antennae to, because it won't be perfect in the sense that people's circumstances change, and if we can help someone, we want to be able to do that. So appreciate that.
Thank you for the effort.
Please keep me updated, particularly on the dental thing. That's important to me.
Yes.
And we'll see you next month.
Absolutely. I did want to mention on the same Senate Bill 86, there are provisions in there that deal with also trying to support the availability of workforce. So that's a bill you might want to take a look at based on your questions.
You have given me my weekend homework assignment, sir. Thank you.
You're welcome. Thank you.
Well, there we are. And usually at the end, we have an encore presentation from John Williams. Nobody got that? John Williams?
I
Boston
did,
Pops,
Chairman Pearson. Thank you.
Encore? Thank you.
So,
We're trying not to encourage you too much.
How's that been working?
So, Chairman Pearson, if it is the pleasure of this committee, you have had as your standing operating procedure, and it's worked out fairly well as it relates to scheduling and avoiding conflicts with the fiscal committee, to meeting on the fourth Friday of the month. and the meetings typically start at 10 in the morning. If there is a conflict that does arise, that this group meets at 1 in the afternoon. It seems to be a good process, good system. So if that's something for your consideration you'd like to continue, that would mean the next regular meeting of this committee would be tentatively Friday, February 24th at 10.
Can you tell us what's on the agenda?
Tentatively on the agenda, which is driven by various statutory and chapter law reporting requirements, would include, well, I'll start with one that is neither of those. Very important, however, is the update from our commissioner, our interim commissioner, Lori Weaver. As she had mentioned, she'll be able to provide more details around the roadmap and other updates that are critical for this committee to hear. In addition to that, tentatively, we have under Senate Bill 147 from 2021, a final report on the spend down requirements. Our agency has conducted educational opportunities within our agency for those frontline workers to be better educated for uniformed application of the spend down requirement, particularly as it relates to mental health delivery of services. You had an interim report. Karen Hebert, our division director, our division director, and also Don Tierney, formerly Don Landry, were the ones who presented. I would expect that they would be presenting as well for their final report. In addition to that, there is also a statutorily driven report under RSA 128.11 that falls under the health officer statutes for an annual report from the health officers. Again, these are tentative and also subject to additional items through the chair for items that this committee might have a particular interest in.
Thank you very much. If the committee would like to hear something that is not on the tentative agenda, please let me know as soon as possible so we can line up the people to speak. I want to give the committee an update before we close. Last fall, I formed two special subcommittees. One was on emerging medical technologies. Let me give you very briefly the history of that. The late and much beloved Catherine Rogers sent a bill to Health and Human Services and Elderly Affairs Committee on that broad topic. Representative Soloway convinced us it would be the best thing to send it here. It could happen faster, and to send it to this committee and form a subcommittee and come up with a report and go from there. And Representative Soloway did this. I appointed a subcommittee that he chaired. They came up with a report, and that report turned into a bill, and we will be looking at the Emerging Medical Technologies Bill very soon. So that's the update on that. That's the story. I don't, I'm sorry. You know I don't know details, but I think it's coming to your committee. Okay, great. The other one, Representative Soloway has a family member who works for the I-Team, Spotlight team of the Boston Globe, and gave me a heads up about front page continued inside on 4 complete pages that a particular surgeon in New Hampshire, his malpractice company has settled 20 malpractice cases against him, and that was reported on the website of the Massachusetts Board of Medicine, but was not reported on the website of the New Hampshire Board of Medicine, even though that surgeon practiced here. And so Representative Soloway, again, retired epidemiologist, retired member of Health and Human Services Elderly Affairs Committee, retired member of this group, suggested a subcommittee, which he insisted I chair, on the issue of transparency at the New Hampshire Board of Medicine. That subcommittee met on October 3rd, 17th, and 31st. We had lots of people on board. Some of them I'm looking at. We took testimony, and we came up with a couple of tentative conclusions. One was that perhaps there needs to be some changes in the protocol as to what gets reported on the website. It may well be the case that the New Hampshire Board of Medicine did nothing wrong. They were operating under different rules than the board in Massachusetts operates under, but we don't know that. And what we are looking at is, should the rules be continued or should they be changed? The second conclusion we came up with is that the Board of Medicine has a retired, part-time, volunteer physician investigating, and perhaps there could be greater staffing of this when complaints are made. This is no fault of the one who's doing it on his own dime. This is simply saying there may need to be more. Representative Ullery filed a bill. I was co-sponsor of it. It was heard by ED&A that some funds at OPLC, Office of Professional Licensure and Certification, all of the funds they receive from licenses, after their expenses, all the leftover money goes into the general fund. Could some of that be non-lapsing? That is to say, they get to keep some so that they, seeing a need, could have already hired additional staff. Does it have to wait for the next budget cycle? That bill's been heard in EDA and will come to the floor. Where I wish to go forward with this transparency, yes, there is a bill that will reestablish basically the subcommittee. It will look at rules and regulations. It will also periodically oversee Board of Medicine to make sure the rules are being followed. That's a bill that will be coming up in Health and Human Services, and I'm prime sponsor. While that is running its slow course along the way to being established, probably over the summer, late fall, I will be pulling together just as an individual. I'm not convinced yet that I want to establish another subcommittee, but I do want to have some conversations. So should the bill establishing a Board of Medicine Oversight Committee be passed and signed into law, a lot of the work in that group will already have been done. So that's just an update on those two subcommittees. And boy, I miss Representative Soloway. Yes, Representative Murphy.
Thank you, Mr. Chairman. For Representative Weber, the first bill, the medical technologies, is 323. And the second bill, the one on the Board of Medicine, is 322. And they're both being presented next Wednesday in Health and Human Services.
I'll see you there.
Thank you. And now we all know who has read the calendar and who has not.
Well, I worked with our chairman on those two, so I was interested.
Anybody else on the committee? Anything else?
I
Representative
just
Weber.
wanted to point out that doesn't mean I'm disinterested. I'm just lagging behind.
We have each other's backs. That's how we work here. Okay, good. Thank you. See you, if not before, 3 weeks from today.
Speak out of turn at the beginning of the meeting.
Not at all.
I've been presiding all week.
I know. I know.
It's hard to try to
Do I
push
look
it.
angry?
Well, no, you went like this.
Oh, that's reflection. I was talking to Gordon Chill. That was right.
Did I open the meeting okay and all that?
So I shared it with
I said yesterday. Appreciate the consideration and arrangement.
In the meantime, I also talked to Senator Cross, send me the email. I never put in how that but I said, I'm going to invite you, Senator Gregg, Senator Shibwall to a meeting with Rick, because I shoot my house last Bradley the other day.
Is that protocol? Is that okay for me to like after the meeting, it's like 5 minutes? It's been, well, and just so you know, I think everything's fine. Yeah, no, I don't.
That puts it in, as far as I know, billable hours.
So then, I saw him in the hallway. Okay, that's cool.
Get to